Well, I just would like to take a moment to welcome everyone to our Georgia Lung Cancer Roundtable annual meeting. We realize how busy you are, so we are so thankful that you made the time to join us today. I'd just like to thank all of the people that helped make the roundtable: American Cancer Society, the Georgia Cancer Control Consortium, also known as GC3, as well as our sponsors for this event today, Phoebe Putney Memorial Hospital, as well as AstraZeneca. Next slide. Phoebe is our premier sponsor for this event, this year's Georgia Lung Cancer Roundtable. So we just want to say thank you again, Phoebe, for your continued support with the American Cancer Society and our efforts. Just really quick, I would like to just call attention to our agenda for the day and some just housekeeping rules. I think that we are pretty deep into our virtual meeting capacity, so everyone is very familiar, I hope, with Zoom, but there is a chat. Feel free at any time to drop questions in the chat, or you can DM me personally, Jessica Davis, if you have questions that come up. We're going to help everyone be muted during the presentation, but feel free to unmute yourself to come off mute and ask a question. This meeting is going to be recorded. If you would not like your image recorded, you can simply turn your video off. But we want to record the meeting for those that aren't able to attend today or may have to leave early so that they can catch all of our updates from the annual roundtable meeting. So I'm going to walk you through our agenda for the day. This is the welcome by me, Jessica Davis with American Cancer Society. Up first, we're going to have Chris Draft to give an update on the White Ribbon Project, followed by Dr. Hotz, who's going to give some GC3 updates. Rana Bockley from the Georgia Department of Public Health is going to share some updates. And then we are going to go into a time of some subgroup updates. Our subgroup leads have already met to record these sessions because there's some of our group leads that weren't able to attend the meeting in person. So that will be a recording. And then after that, we are going to do a live Q&A panel for our subgroup leads. So at any time during any of the subgroup updates, if you have questions, feel free to put them in the chat. I'm going to help collect those, and then Dr. Jones is going to do a live Q&A panel with our subgroup leads. And then finally, we will wrap up and adjourn for the day. So without further ado, I would love to introduce everyone to Dr. Adam Jones. He is our 2021 Georgia Lung Cancer Roundtable Chairman, and I will turn it over to Dr. Jones to start us off.
All right, thanks, Jessica. Looking at that picture now, that was many years ago before I had any stress or children or any responsibilities in my life. I want to thank everyone for being here, committing these couple hours out of the day. Of course, it's better when we can get together, and we would really like to do that again next year. But I do enjoy getting to know everyone involved with the roundtable, and I've really enjoyed these relationships over the years. And I'll thank Jessica again at the very end of this thing. Thank you for putting this together. Your work has been tremendous here, including reminding me when things are due. So before we get into our first speaker, just want to give a plug to both the Braves and the Dogs. I know everyone on this call both really support both of those teams. Not a single Gator fan on the call, I'm sure, or a Houston fan for that matter. We'll kind of keep going. So as Jessica said, we have several guest speakers today, in addition to a kind of a special video that these subgroups produced. And really my vision for that was to give us something that we could develop in this year that could be carried forward. I feel like anytime any member of this group has an opportunity to speak to their hospital or other physicians, it can be something that can be shared. It can be something that can be used to even inspire another program. It can be something we can reference many years from now. So I'm really proud of that work, and each subgroup put their individual spin on it, and I'm real proud with how that came out. I'd like to just go ahead and kind of get into our first topic today. So we have Chris Draft with us. Many of you know Chris. I'll give him a little bit of an intro. He spent the first part of his life cracking heads on the football field, and he will come visit you any day that you tell him you are motivated to do the work and to impact the lives of others. He champions the White Ribbon Project. He'll give you some of those details behind that. And I'd like to turn it over to Chris. Thank you. Chris, are you there? I saw him earlier. I know he was traveling this morning.
He's here. Maybe he's muted.
Well, we can always.
Let me unmute him.
We can always come back. Is he on the call?
He is.
I'll text him.
Maybe tied up at a cafe somewhere, waiting on his coffee.
Dr. Jones, he's on, but he's on mute. I don't know if he's trying to speak, muted.
Jessica, do you guys have to unmute him from the top?
Yeah, well, I am asking, yes, I think that he just logged off. So maybe he was frozen and he's rejoining.
Okay. While he's rejoining, I'll tell you a little bit more about our speakers. I know Jessica did that already. Dr. Haas has been a part of state initiatives over the last couple of decades in an effort to improve cancer outcomes. His involvement with the Georgia Cancer Consortium just continues to go on. He brought me on a few years ago to help from the clinical side. I truly believe that that these roundtables and these statewide efforts are go best whenever we have a combination of physicians and other members, including DPH, ACS, and other staff members. So Dr. Hotz will talk, and we have several subgroup co-chairs on the call as well today. So we have Chris back with us already.
Dr. Jones, man, I am so sorry. Somehow there was a glitch in the matrix that made it where as soon as I was going to go on,
that's okay. You got it.
So I'm so excited to be here and speak to our Georgia Lung Cancer Roundtable, and you guys will be able to see some pictures of Dr. Jones and I putting in work down in Albany, Georgia, when I went down to see him, and we made some white ribbons. But before I talk about the work that we did down in Albany together, I want to just talk about what the White Ribbon Project is and where it came from. And so if you can see that there's some pictures of Heidi and Pierre. If we can go to that next slide, you'll see these amazing people. Heidi and Pierre they live in Denver, Colorado, and last year during lead up to Lung Cancer Awareness Month, they asked the question, what are you doing for Lung Cancer Awareness Month, to Kaiser, to CU that are right there in their community, and they didn't have a plan. They didn't have a plan for Lung Cancer Awareness Month, and so unfortunately, they were like, well, what can we do? What can we do? And finally, it got to September 27th, and they'd asked the question so many times leading up to it that Heidi turned to her husband Pierre, who was a primary care doc at Kaiser and amateur woodworker, and said, can you make me a big A white ribbon, or a big such and such white ribbon that I can put up on the door, and I won't have to apologize, for raising awareness. I won't have to. We can take control, put it up on the door. We can put facts on the lawn, and regardless of what the Cancer Center does, regardless of what organizations do, we do not have to wait. We don't have to worry about just what they're doing, yet we are concerned about it, but we don't have to stop what we do because of that. So they put the ribbon up, shared it with some local Denver advocates on a Zoom site, yet got that done. And the other people, she had challenged them, Heidi had challenged them to wrap a ribbon around their tree, or really, again, the same way, just own the fact that each individual has an opportunity to raise awareness. Doesn't mean that each individual is going to completely change the world, but if they do their part, it's a win. And so as she's sharing that, they said, what about that ribbon behind you? Could we get one of those? And Pierre said, absolutely, I'll make them for you. And that was the start, just that those Denver advocates of asking for a ribbon, combined within some national Zoom calls with Longevity or myself with Team Draft, and more survivors asked for ribbons. And what Heidi realized is that if they were willing to ask, that meant that they were willing to put it up, they were willing to share it. And if they were willing to share it, that meant that they were not ashamed of making it clear that lung cancer awareness mattered. And because of that we would bring awareness. So it was worth it for them to send them out, because if they were willing to stand,
Dr. Jones, we might have lost Chris again.
and then realize that there's no way that they're going to be able to send out as many as just by themselves individually, when we know that 235,000 people are going to be diagnosed with lung cancer. And so admit that people needed to make them locally. They were going to have to be able to do that. If we were going to be able to get to all of our people and let them know that they're not alone, it had to be done where it was, so you wouldn't have to ship them, but also was an opportunity to make it clear by the people that are in the community who, that they care. And so I say that I got a chance to go down to Albany, Georgia and hang out with Dr. Jones. Dr. Jones accepted the challenge to make sure that the survivors and just advocates and people that touch lung cancer in Albany, that they would get ribbons. So if you can see the next slide, you can see Dr. Jones and I going to work with his neighbor Chase. We're over there at the house, and again, the ribbons don't just happen. You have to make them. And so that's Dr. Jones putting in work. He's made a challenge to all of Georgia to make sure that we get that done. It's, in November, that we want all of our survivors to be able to get ribbons, and really in doing that, again, celebrating the survivors, but also bringing our community together so we have an opportunity to be able to make a difference. And so you can see on the next slide, so Dr. Jones, we put this together, but our local high school said, can we be a part of it? We have to do community service anyway. And so look, we got cheerleaders, we got football players, we had the local media, Dr. Jones looking smooth on the local media. They all showed out. Jessica was there down in Albany, and it just, the ability to raise awareness with the community, and you can see how we don't have to do a whole bunch. They were ready. They had to do, they have to do community service, but they were so excited to be a part of it. Did a great job of painting, great job of signing, great job. The ribbons will be labeled because we needed to let them dry, but they were bought in, they were excited, and there wasn't like, oh my goodness, there's a stigma, we don't want to do it, but really, there they were. And if you go to the next slide, you're just able to see, well, why does it matter? I mean, this tremendous team that Dr. Jones has, there's a part of Phoebe Putney. It's not surprising that they are one of the title sponsors here. They are committed. They're committed to making a difference. And, we have to celebrate our victories. And so my hope, and the hope of Heidi and Pierre and the rest of the White Ribbon Project, is that we use these ribbons and recognize that we need to make sure all of our survivors know that they are loved. We need to make sure our caregivers know that we see you and we care about you too, but also that all the people that are on the front line, so all of you guys that are making a difference, that we don't move forward without you, right? We don't move forward without your work, without your commitment. And so it's important that we want to make sure all the folks that are on this call, that you guys all get ribbons, and those ribbons will be with love and appreciation. And then again, challenge you, just like Dr. Jones has already done, to make sure that we get ribbons to the survivors, at least during November, and let them know they're not alone. And ideally, with all you guys signing on the back, your thoracic teams sign on the back, so they know there's a team of people fighting for you. So that's the White Ribbon Project, man. Excited about it, how it's been able to grow, but just recognize the growth has come from people on the ground accepting the challenge to stand up. Accepting the challenge to stand up and not just say that lung cancer matters and lung cancer awareness is here, but really to stand up and let people know that they matter. Let them know that we care about them. Let people know that they are appreciated. So as we're here in Lung Cancer Awareness Month, if you guys don't have plans, hopefully you do. If not, we still have time to do a ribbon build. I'm here in Long Island, New York. You guys can see some of our folks in the background. That they're making some ribbons that are going to go to Sloan Kettering. I'm going to have some other ribbons that I'm going to be taking down to New York to give out to some other survivors. And there is plenty of time, because all you have to do is just want to get it done. You're not going to make enough in one day, but whatever you make is an opportunity for those individual people to know that they are cared about. And it's an opportunity to bring the community together. So if you haven't thought about it yet, I'm here for you. We're here for you to be able to get it done. And then just know that we appreciate all the work that you guys have done. And we know that it's making a difference, because that's the only way we move forward with lung cancer. Thank you.
Thank you, Chris. Buddy, Fantastic. I'm just going to add a few things to that. Embracing the White Ribbon Project and getting it to your survivors, that is the most genuine, in my opinion, the most genuine way to reach out to your folks and let them know that you care. I consider it a win all around. What we're doing is incorporating it into our Lung Cancer Awareness Month down here. By celebrating survivors, you're also bringing attention to screening. And that is at least what we've committed to do. And yeah, we've made that challenge to the roundtable. Just think if you could start a little White Ribbon Hub in every hospital system in this state, just think how much that will grow, and just think how much awareness that'll bring to screening. Thank you, Chris. And he's serious too. He will come. He will come if you tell him you're ready.
Absolutely,
right?
Absolutely. You know, Dr. Jones and I, the pictures that we took, if you see us making ribbons, those ribbons were for me to go around Georgia with, so we can paint some more. Dr. Jones had already made 70 of them that the young kids had painted. So no, I'm ready to go. So don't think if you guys want to get it done, I'm getting in the car, I'm rolling, I'll be there. Right? Let's make it happen.
Yes, sir. Thank you, Chris. So we'll transition. We did have Dr. Hotz join. Jim was in the middle of his busy clinic in Baker County this morning, and he promised me he'd be ready by 11:45. So we'll give the floor up to you, Dr. Hotz, if you're ready.
I'm ready to roll. Thank you, Adam, and thank you for the great work you're doing with Chris there. Let me just start out by saying I love the football analogy. You know, all football teams have a plan they put into, and they have plays to run, and they're very scripted about what to do. And then they look at the game films to see how well they execute. And what we're trying to do is perform. So we have a state cancer plan, which is kind of like your playbook for controlling cancer in the state. I've had the pleasure of co-chairing that since it started in 2003. It's broken down into 5 sections: prevention, screening, staging and treatment, survivorship, and palliation. And then we roll it out every 5 years and we have specific goals. What we try to focus on, you know, are the issues where we have a lot of opportunity to gain. And when you look at the cancers that kill Georgians, every year about 16,400 people die of cancer. 5 cancers constitute 53% of all the deaths, and all 5 of them have a lot that we can do as a state. When we talk about things like screening and prevention, we got to do that and think about it for 10 million people. You know, there's about 300,000 or so cancer survivors or people been in active treatment. But when you take on planning for a whole state, you've got to have the ability to actually implement and follow those plans and see what we do. So, you know, I'm going to give you a little bit of a history lesson. I may look old in that picture. That's because I am. I started medical school almost 50 years ago in 72. In 1972, there was only one screenable cancer. That was cervical cancer. 1957 it started. We now screen at 86%, pretty darn good. And our cancer death rate from cervical cancer is now down in the state of Georgia to 420. It's the leading killer in undeveloped countries for cancer. So, you know, we know what to do with cervical cancer. We actually know how to prevent it. So HPV vaccination is a big thing because we can eradicate it by year 2030 if we get to 80%. So that's a pretty easy one. The next one would come to breast cancer. That was started after I was in medical school. In 1976, mammograms got approved. We're now to 70% screening rates. We've reduced our breast cancer death rate significantly. And every year, 1,410 people die of breast cancer. We have the breast and cervical program. We have a pretty good strategy of how to do that. You know, a lot of people are into the awareness business. In 1986, we started PSA screening, dropped prostate cancer deaths significantly. And then, we got into the concern about, how much are we harming people? The U.S. Preventive Services Task Force gave it a level D recommendation. So what we did is developed a roundtable to deal with all the complexities of prostate cancer screening. We're starting to see less screening and a greater uptick in high grade and advanced stage disease. So that was something where we figured a roundtable is the way to really get everybody on the same page. For colorectal, it's a bit frustrating. I watched my dad die of colon cancer. In 1993, the first definitive studies by Jack Mendel in Minnesota and Sidney Winauer, you showed you could, number one, do a guaiac test, and then you could do a colonoscopy, and you could significantly reduce colon cancer death rates. 25 years later, okay, our screening rates nationally were only 63%. If we got to 80%, which is kind of the standard of excellence of screening, if we got to 80%, we would save 203,000 lives by the year 2030. In Georgia alone, if we got to 80%, it would be 386 less people die of colorectal. Why this long delay to get screening out that works? How can you accelerate it? Well, if you put roundtables in and you get everybody in the state on the same page, you can accelerate. We started one of the first state roundtables, and there's a national roundtable. And, we have to adjust for certain things with roundtables like COVID. COVID took us back 5 years. We look at community health centers reporting, they went back to where they were 5 years ago. So it requires a lot of people working together to figure out how do we get back to screening. So there's one in which it works. We have a roundtable, but that only amounts for 10% of the cancer deaths. Breast is 8.5% of cancer deaths. Prostate is 6.5. The mother lode of cancer opportunity is in colon cancer screening. 4,200 people are projected by American Cancer Society to die of colon cancer this year. 4,200. 25% of all cancer deaths are from lung cancer. When we did our cancer plan, the current plan is 2019 to 24. The past one in 2014 to 19, I had this crazy guy, Dr. Mayfield, came in and said, we want to start a lung cancer roundtable. And I said, what is that all about? Well, we were the first to start it. Very conclusively, there was data showing out that screening for lung cancer makes a difference. And in fact, 10 years ago, October of 2011, the NCCN was the first organization that recommends a spiral CT scan. So we're 10 years into it. And you know something? We don't even know what our screening rates are. It's not a requirable, reportable thing, even though it's highly effective. The other challenge is a lot of people don't know about it. So, when Chris and you guys are putting out those it's very important to get awareness out. And of course, this is Lung Cancer Awareness Month. So we have a major opportunity to make a difference. And the interesting thing about lung cancer is there's a strong prevention arm in it, obviously in screening, in getting people to stop smoking. There's a big screening arm in it that is grossly underutilized. Most people think our rates are around 10%. You've just changed the age of screening and taking it down to 50. Big COVID impact. The NCI estimate increased deaths from breast cancer because of COVID is 5,000. Colon cancer, it's 4,000. What's the impact on lung cancer? I don't know, but that's what this roundtable is to deal with. So we have a very effective screening that is grossly underutilized in the state and the nation as a whole. We have very effective prevention, and linking that into the roundtable that you guys have done is a tremendous idea. We have highly effective therapeutics now. And the great thing is we're actually talking about now having a group of people who are going to be lung cancer survivors. So the challenge I say to you guys in this roundtable and why it's so important is we probably have the most to gain as far as cancer control in this one arm, in this lung cancer roundtable. And this gives you an opportunity to put together all the people that are participating in lung cancer control in one place and one time. So I'd like to thank American Cancer Society for helping support this, the hard work of Adam Jones and his predecessor, Dr. Mayfield. And it's been my honor to present. And, you know, as my father died of colon cancer, my mother died of lung cancer. And on her deathbed, she made me promise that I would work hard to make certain it didn't happen to her grandkids, my children, and her great grandkids. So it's an important job you got to do. It's very complicated, but there's probably no more important arm in cancer control for the state of Georgia than the roundtable that you're now being part of today. It's my honor to present to you guys, and later I'll be glad to take any questions you may have. And thank you for the work you do, Dr. Jones.
Fantastic. Thanks, Jim. Appreciate you. And I'll take a minute and echo what you just said. We have the greatest impact or greatest potential gain when it comes to lung cancer. I continue to kind of preach that locally. That's what we talk about in our own hospital committees. We're screening a small percentage of the population. That screening or at-risk population at least doubled on paper. We had a fairly significant impact in terms of screening reductions over the past year and a half with COVID, which is ongoing. At least we're, I guess, as a state, figuring out ways to live with it or deal with it, so to speak. But regardless, yeah, I think our greatest gain is a lung cancer screening and reducing lung cancer mortality. We'll and Dr. Hotz will be with us for most of the call today. So yeah, we can certainly feed in some comments through the electronic panel here, and we can kind of get to those later, Jim, if that's okay.
Okay, good.
Thank you. So we'll go ahead and move. We have Rana with DPH. I've worked with Rana in several groups. Typically when I say, I wish I knew a number for something, she would just go find it. So you're very diligent, Rana. I know you have a good team. And I asked her to come up with some specific data points in terms of the burden of lung cancer for the past couple years. Specifically, hey, how have things changed since we began screening? Do we have a change in incidence? Do we have a change in death rates? A change in early versus late stage cancer? So we're going to have her go through those coming up here next. Thanks, Rana.
Right, here we go. All right, I think you can see my slides. Thank you, everyone. Appreciate it. Having Chris and Dr. Hotz ahead of me is really exciting and made me really enthusiastic about joining and being part of this group. It's really very interesting listening again and again to Dr. Hotz. I always learn something from him. And I'm glad to report that our lung cancer is really on a good side. And hopefully all the work you're doing will show in the near future, continue to show in the near future. So just to go through some of our death data and morbidity data or incidence data, I've decided to give you more up-to-date data this time as we have our 2020 death, and we have a lot of data on our Georgia Public Health website. So looking at our last 5 years, 2016 to 2020, even though cancer is still the second leading cause of death in Georgia at 17%, looking at lung cancer specifically, it is our fifth leading cause of all causes of death for all age group combined. So it is a significant, we have a significant number of deaths due to lung cancer. How have we been doing since 2000 for lung cancer? Among all cancers, lung is still the leading cause of death in Georgia. And it is among male. It is decreasing, as you could see, and it has been really decreasing significantly and continue to decrease up to 2020, which is really, really good to hear that our lung cancer mortality is on the decline. And the decline is really sharp and started since 2004. We have been declining at about 3.7% each year. Among our Black male, about looking at our diversity in terms of death, both our Black male and white males, lung cancer death is really decreasing significantly, and it is really decreasing at a faster rate among Black male in Georgia at a 4.2 compared to our white males in Georgia. If you're looking at all deaths, lung cancer is still contributing, in 2020, is still contributing to 1 out of every 4 cancer deaths among males in Georgia. Our females, also the lung is still the leading cause of cancer death among our females in Georgia. It is declining, but is not declining as fast as it is among our males in Georgia. The decline is at 2.6. It is a significant decline. Whenever you see a star, means that decline is a significant, and the decline started later than the counterpart, than the male counterpart. So for our female, the decline in lung cancer started in 2007. When we look at our racial disparity, even though both white females and Black females are both going down, trending downward, you still see a high mortality rate among our white female. Both the white female and Black female, their decline is about the same rate. So in order to really decrease or reduce the gap between our white male and white female and Black female, we really need to kind of push toward more intervention to decrease both mortality for both Black and white male and a female at a much higher rate. In 2020, 1 in every 5 deaths among female were for lung cancer, was due to lung cancer. Now looking at our morbidity or cancer incidence, and that cancer incidence is normally collected using the Georgia Cancer Registry. And as a part of the problem with the cancer registry is completeness, takes about 20 months for data to be complete. And actually we just released 2019 data, or just submitted 2019 data to our national organizations. So soon we will have 2019 data. But up to 2018, our lung cancer incidence was decreasing, and it is really decreasing at a fast rate, starting with 2016. For our males, in terms of non-Hispanic Black and non-Hispanic white, males because we're using the cancer registry, our ethnicity data is much better than our death data in terms of ethnicity. So I'm able to specifically talk about non-Hispanic Black and non-Hispanic white. So it is trending downward. And you can see that actually our non-Hispanic Black male, their trend is going faster than the non-Hispanic white male, and the gap is really is a higher mortality rate among white males, non-Hispanic white male compared to non-Hispanic Black male, and it has been it is going down, but there is this, the gap is increasing compared to 2000. In 2000, we had the difference between non-Hispanic white male to non-Hispanic Black male was 2%. In 2018, that gap increased to 7%. Looking at our trend in terms of early versus late stage disease, both for our males, non-Hispanic Black male and non-Hispanic white male. For non-Hispanic white male, it is going up. Detection at early stage is going up, and that upward trend started in 2016. However, for our non-Hispanic Black male, that upward trend, you could see only 2018 is up, but it did not really make it as significant. So for us to really push toward early stage, we definitely need to do more screening where we are able to increase or shift our stage from late stage to an early stage disease. The gap between our non-Hispanic Black male to non-Hispanic white male, it is decreasing. And you can see in 2018, the difference is 12%. For late stage disease, that's a good story for us. It is going downward, and it is going significantly downward at a much higher rate for non-Hispanic white male, and is significantly going down for our non-Hispanic Black male, but at a lower rate, which is 2.3% per year. However, the gap between our white and Black is decreasing. It was stable for a few years, but now it is closing. We're closing that gap. For our female, it is the second leading cause of incidence. It is going downward in terms of incidence. However, that again, I'm sorry. The decrease or in lung cancer incidence among female is not as fast as among male. The decrease is only 1.5% per year. Looking at our differences in terms of race, ethnicity, there is a bigger gap, a way bigger gap between our non-Hispanic white females versus non-Hispanic Black female. And that gap is has increased in 2018 compared to 2000. Overall, when you look at 2016, there's lung cancer for every, there's one lung cancer, newly diagnosed lung cancer for every 8 cancers in the state of Georgia. In terms of race, ethnicity, and stage of disease, it is going upward, which is really good. You can see that it is really going steep up. At 15.9 for non-Hispanic Black female and 14.6 for non-Hispanic white female. So that is really good news for us that we're shooting up in terms of identifying patient or females at an early stage. And again, for our late stage disease, it is decreasing, and it is decreasing significantly, and kind of a similar rate of decrease between non-Hispanic Black female versus non-Hispanic white female. But that gap is not changing. We're not shrinking the difference between the non-Hispanic white females and the non-Hispanic Black female. And it makes sense because they're both going downward at a similar rate. So if we are to bring the white female to the level of where the Black females are, we really need to increase the decline in identifying patient at a late stage for non-Hispanic white female. How are we doing in staging and survival? So I'm still, this is very important to see that the majority of our patients are still being identified at a very late stage. More than 60% of our lung cancer patients, whether we're talking males or females, they are being identified at a very distant late stage where intervention is not as successful as when you're finding it at a localized stage or a regional stage. And you can see these are the survivals, even, I mean, survival for non-Hispanic Black is a lower when you compare to non-Hispanic white. That is an issue we see in several cancers, even though you identified the cancer at the same stage. However, the survival for our non-Hispanic Black is still at a lower level than non-Hispanic white. So overall, we are really doing well in terms of our lung cancer mortality and lung cancer incidence. It is going downward. I feel like your approach in doing lung cancer screening coupled with our tobacco intervention and not starting tobacco use has been really successful. And now it is really time to work further on the disparity in terms of treatment for non-Hispanic white and non-Hispanic Black. And I was participating in the biomarker testing ECHO, which I thought that was really very important and very timely for us to have in the state of Georgia, and hopefully to improve our treatment for our lung cancer patients. Thank you. And this is what I have.
All right, thank you, Rana.
Thank you.
There was a question, and from Angie. Basically, the question is, and obviously those numbers, the data lags behind our time a little bit. You did bring us up to speed, but we know that there was a change in society beginning in 2019. So the question is, in light of decreased screening rates and pandemic impact, do you believe we will see a change in, maybe those early stage cancers will dip, maybe the advanced stage cancers will rise? That was the question, essentially.
Yeah, we're really trying to keep a close eye on it. We have been receiving our electronic path reporting from all reporting facilities. We are going to try to make those cases where we can look at the stage as quickly as possible. We're crossing our finger to continue to see that decline in the incident, on the incident side. It seems to have declined in terms of mortality that continues, but we will keep an eye on the incidence and see how it's going to go in 2020. We do know that we have a decrease in the pathology reporting by 10%. So we're hoping that people, especially those with lung cancer, have continued to go to their physicians and receive the appropriate diagnostics and treatment.
Okay.
I have a
Yes.
quick question about the gap between Caucasians and African Americans. Were there any differences when they, for example, want to implement screening to start at the age of 50 instead of 55, since there are differences with, with lung cancer being prevalent at younger age with the disparities?
I actually don't have a lot of information on screening, unfortunately. Like Dr. Hotz mentioned, at this point, we do not collect information on screening, so I'm not really sure how much screening impact this data. We do think, because normally we're using the screening information we know from breast and colorectal and cervical, that it does work. I think that is a question would be for the committee to decide if African American need to be screened at a younger age. But I feel like most of the disparity is really among the white population versus the African American population. So I feel like the influence, the intervention need to be hitting both group. And there is shouldn't, I don't feel it's as a big difference in terms of disparity compared to other cancers. We know that smoking among our African American population is lower than among our white population. And I do think we need to be more aggressive in terms of not taking on tobacco use as early as possible.
Can I ask
Okay.
a question?
Sure, go ahead.
So I'm a lung cancer patient, survivor, actually, almost 8 years in January, stage 4 adenocarcinoma, not a smoker. I'm so excited that this group is getting together and working on lung cancer, and we just can't go fast enough. For me, I just lost a friend yesterday. We lose them every day. Does the Department of Public Health have any kind of budget that they can work with to put a campaign out there for public awareness? I know you're doing data analysis, but that's after the fact. Is there anything to message to the public out here in Georgia to, and otherwise it's really left to the health systems that are, I have to say, they don't do a really good job of informing the public.
Yeah.
And so some do, but does your department have any budget for that?
Not for lung cancer screening at this point. Most of our funding, we're really heavily federally funded for our prevention activities. So most of the fund is really toward tobacco use and reduction in tobacco use, all type of tobacco use. I'm not sure, I'm not aware of funding or grants opportunity for implementing lung cancer screening activities I'm not aware of it. But we do work very closely with the GC3 we're really supportive of the lung cancer screening. I wish we could do way more than what we can. So we're hoping in the future when there is an opportunity for us to apply for funding that we can. At this point, we don't.
All right, so thank you, Rana. And I agree. I think we could always be doing more at the state level in terms of awareness for screening. State has been a bit, just say, sidetracked over the last year, but we've also had an explosion of programs doing lung screening and a greater eligibility criteria. So we're all kind of struggling to promote that in responsible ways within our own systems. We are actually somehow running a bit short on time. I wanted to go ahead and get to the video that was put together by the subgroups. Again, you'll kind of recognize some of the members in these different groups. And afterward, we would like to make this available to everyone on the call to use in any way that they see as a positive impact way. So without further ado, we're going to have Jessica go ahead and start this snippet. And this is essentially an update or a status of where we are in this year. And you'll hear from some of the subgroup leaders here as we go forward. Good afternoon. This is Dr. Adam Jones with the Georgia Lung Cancer Roundtable. This is our segment on quality, specific to the quality subgroup. For the roundtable, I have Dr. Norm Thompson. He is a professor of radiology at the Medical College of Georgia at Augusta University and vice chair of radiology quality, assisting in this dialogue. Norm, good to have you.
Thank you very much, Dr. Jones. I appreciate it. Dr. Jones asked me to address 4 questions in the quality realm for lung cancer screening. But before I start working on those questions, I'm indebted to Dr. Jones's encouragement, support, and feedback for preparing this, and appreciate the support that Stephanie Lamar and Deb Jeske has provided the committee. So thank you all. Brief introduction. And the first question that Dr. Jones asked me to consider is, what are the key components of a high quality screening center? And really, we come back to the key triad of a high quality imaging center, and with deference to Dr. Mayfield, they are ACR accreditation, which provides a quality component of the imaging and the imaging interpretation. Nurse navigation, which is key for helping subjects and their families, and when they become patients and their families, navigate a very complex process for screening and then ultimately diagnosis and treatment of abnormal findings. And then the foundation is a well-organized, multidisciplinary provider team that puts the patient at the center of care. So let's first just briefly talk about ACR accreditation. ACR accreditation is a robust method to ensure that CT image quality meets standards, doses meet standards, protocols are reviewed, the images are reviewed by an ACR radiologist and passed as to appropriate quality and dose. It ensures that you are a registry participant, you are consistently reporting using the LUGRADS lexicon, and that you and your teams have adequate competency and continuing education to maintain high image quality. Nurse navigation has multiple roles within a lung cancer screening process, everywhere from outreach to intake to navigation for routine screening to navigation for workup and then ultimate treatment decisions. So they are a core component to help navigate patients and also oversee the quality processes for a lung cancer screening program. The third and base component is really a strong patient-focused multidisciplinary team. And this requires a whole host of different specialists and different support personnel. Smoking cessation is a key part of this process. And navigation is the glue that keeps all of these pieces together and guides our subjects through the system and helps keep the caregivers straight as we try to work through lung cancer screening and then lung cancer diagnosis and treatment. Dr. Jones asked me to consider what is the single most important component and why. And there's no question, navigation is the key. As Dr. Mayfield has said several times, the three key components of a screening program are navigation, navigation, and navigation. The navigating team ensures eligibility on intake, that proper coding and billing is followed, that findings and recommendations are clearly communicated to our subjects, our providers, and help close loops to ensure that nothing falls between the cracks. They engage in provider and community outreach, they assist in workups, and they keep patients in the center of lung cancer care. Third question Dr. Adams asked me to consider is, how do you balance the need to meet volume with maintaining high quality screenings? And that is a difficult process, and it is indeed a balancing act, particularly in the era of COVID. The challenge we have is that CMS and insurers reimburse lung cancer screening CTs at the lowest level. They do not consider the additional work needed to maintain navigation, software systems, and additional communication and mailings. So these additional costs are significant, and hospital and practice administrators resist the extra cost. It's important to realize that imaging is sometimes considered in a silo, but it's important to realize that we are part of a larger enterprise and that the downstream effects have significant financial reimbursement for the enterprise. And the answer is we have to learn to become very efficient use lean principles or whatever other performance improvement metric you use to improve processes. And ultimately, reducing lung cancer mortality and morbidity is the right thing to do for our community. It's an enormous burden in the Southeast. And the third question Dr. Adams asked me to consider is, how has the pandemic affected quality? And I think that answer is almost specific to every site and every organization. I'll share what our experience was. In March 2020, as we realized that we were entering a storm of COVID patients at Augusta University Health, radiology leadership paused non-emergent outpatient imaging for 2 weeks. And we took that opportunity to sit back and reassess our workflows, check ventilation, acquire portable HEPA filters, train all of our providers and our techs, and support people on PPE. We started doing COVID testing before potentially aerosolizing biopsy and similar procedures. The institution pivoted to a very robust telehealth initiative to keep outpatient clinic appointments virtual, but there was a significant decrease in our lung cancer screening volumes. And the backlogs have been repeatedly impacted by recurrent COVID surges, particularly the post-Thanksgiving, Christmas, New Year's surge, and then our most recent sort of Delta variant surge has really restricted our ability. Parenthetically, many screening subjects and patients have avoided hospitals and clinics because that's where a lot of COVID is. It's hard to maintain social distance. It's very challenging. And so we've had a lot of subjects self-cancel or self-reschedule. We don't know what the impact of COVID has been on the smoking population, and that's be a subject for future examination. But there's no question that smokers are at increased risk and at high hazard. The other thing that hit us is our ability to do non-emergent procedures such as bronchoscopic biopsies, interventional radiology biopsies, et cetera, severely limited. Staff in those areas were redeployed to inpatient services as we expanded ICU spaces. And so there have been significant delays in screening, in diagnostic workups, in biopsy and other staging procedures, and delays in getting patients in for definitive treatment. So there have been significant impacts to lung cancer screening and lung cancer treatment during the pandemic. And it will probably take us several years to assess the impact, but there's no question that anecdotally we're seeing patients presenting with later stage cancers, and we're having longer intervals between screening than we would like to see. Thank you for your attention, and I appreciate the opportunity to share my opinions and insights with the group.
Great, thank you, Norm, and thank you for your overview, particularly delving into COVID-related impact of lung cancer screening. You have the ear of many providers around the state in this recorded dialogue. Is there anything in summary, anything you'd like to leave others with in terms of, what would be the overarching theme of quality? Any last comments?
I think, as many people have said, navigation and communication are the core pieces of a highly functioning lung cancer screening program. And that's the foundation you have to return to even with the COVID pandemic, is rely on navigation and communication to help our subjects and then our patients work through the system and be treated appropriately.
All right, fantastic. Thank you. Appreciate you being here today.
Welcome to the Navigation Work Group. I would like to introduce you to our members: Angie Caton from Northeast Georgia Health System, Benet Thompson from St. Joseph Candler in Savannah, Tiffany Nelson from Wellstar, and Michelle Ballos and Kincaid from Piedmont.
Hi, Benet. This is Angie Caton from North Georgia. How can people throughout the state of Georgia get access to high-quality lung cancer screenings?
Hi, Angie. Well, there's 3 different ways that they can get access to this care. One, they can refer to a dedicated multi-D or multidisciplinary lung cancer screening program. 2, they can choose a program that is recognized as go-to foundation screening center of excellence. And 3, they can be referred to programs with dedicated lung screening navigators.
So another question we get a lot from patients or people trying to get a screen, does an order for a low-dose CT screening have to come from their primary care physician or a pulmonologist?
Well, there are 4 different ways that a patient can get an order. They can get it from an MD or a physician that is a DO, a nurse practitioner, or a clinical nurse specialist. And nurse navigators can assist with that process.
All right, and this is another hot topic in a lot of our areas, that COVID-19 has caused many delays for healthcare for people across the state of Georgia. How have navigators modified their approaches to reduce delays in lung cancer care?
Well, as a navigator, our patient priority is based on lung cancer risk. And we also reassure patients that we are following all COVID-19 safety protocols. Care coordination in accordance with local policies and procedures is a big thing for us as well.
It's very important.
So Angie, follow-up for us is very important, especially for patients that have a lung RADS 3 or 4. However, if a patient tests positive for COVID, we try our best to adhere to CDC guidelines for follow-up timelines.
I think that, Benet, you're right. That's very important that we follow the latest guidelines. As we know, things have changed quite a bit during the pandemic. And I think that knowing the patient's risk and knowing that they need to be on like a list or something like that to keeping it, that's what navigators can do, help keep list of patients that are COVID positive that need follow-up, and then stay on those patients and those physicians to help the patient get what they need.
Right. So COVID-19 has uncovered many healthcare disparities with low-dose CT screenings and lung cancer care. So Angie, what evidence-based methods can navigation employ to improve health equity for low-dose CT screenings and lung cancer care?
We all know that this is a big issue in the state of Georgia. Nurses, if we and navigators, if we call and remind patients, I think that that goes a long way. Because they trust us and they know that we're looking out for them. Here in Northeast Georgia, we've used client incentives. And so, maybe it's a $20 card after they complete their scan, some small incentive to get them there or to reduce the barriers that they might have for transportation for example, especially in our rural areas. Small media, the use of Facebook, everybody's on Facebook, everybody's on Twitter and Instagram, any kind of way we can get messages out about the importance of screening and to encourage different populations to go screening, and maybe having a message in their language would help also for that. And then patient education goes so far all the time, is that people don't know what they don't know. And so if we talk to patients and we encourage them to do the things that they need to do to maintain their health. And, a lot of them have fears. So as navigators, I know a lot of our work is trying to dispel myths and to reduce the fear that people have about having a lung cancer screening.
So Angie, what is your take-home message for any provider or navigator on the importance of navigation in the lung cancer screening process?
I think, Benet, every chance we get, we need to reduce the patient and provider barriers, whether it's making it a little bit easier in the EMR for the doctor or the nurse to the advanced practice nurse to order the screening, for the patient, whether they know where to go, or like we mentioned, the incentives to go, reducing their barriers, and then talking about adherence to recommendations. So when the multidisciplinary team makes a recommendation, that the primary care physician gets that recommendation, that the patient knows that recommendation and feel like they're part of the team, because you don't want to certainly not include the patient in some of those recommendations. And then I think navigators and providers have a big opportunity to enhance the communication between the whole team. It's just so important for us to make sure everybody's on the same page. And we all have the same goal, you know, is to try to find lung cancer early when it can be treated early and survival rates are better. But it takes a lot of different wheels to keep rolling to get that done.
And thank you so much for listening to the navigation work group. If you have any questions, we're willing to answer them.
All right, welcome to the provider engagement question and answer session. I'm Adam Jones, facilitating for the Georgia Lung Cancer Roundtable. I have Charles Kemp with us today. He's the chair of the provider engagement subgroup. He has provided us with some content, and we'll go ahead with the program. So Charles, can you hear me?
I can hear you fine.
Okay, great. So first question, Charles, is have you incorporated the 2021 task force recommendations into your practice in terms of selecting patients appropriate for lung cancer screening?
I have. We did see some broadened criteria that the USPSTF put out this year, which was helpful in getting more patients into lung cancer screening. I'm making those patients aware of it, so people over the age of 50 now instead of 55, and those who have smoked a 20-pack year history versus a 30-pack year history. All of those people are now eligible for it. One drawback to it that's created a bit of some conflict is just making sure they're aware that CMS is not covering all of these changes at this time. And so as we're getting more people involved, we do have to make them aware that they may have to bear the cost of that until CMS updates their guidelines, which we're all optimistic will happen shortly and within the next year or so. And then stressing the principle with these patients that these are our best estimates on who needs these screenings the most, but this is still a very new screening process. And just like we saw colon cancer screening take a sudden turn this year with colonoscopies recommended for the general population in 45 instead of 50, as had been the trend for years. We're still trying to collect the people who would benefit the most from this lung cancer screening and deciding exactly where that mark is. So just asking people and patients to bear with us as we do that. Okay,
next question. This has to do with counseling for the actual study. So Charles, do you find that the counseling for low-dose CT is difficult or cumbersome? How do you do it technically? And then do you believe counseling should be a requirement in terms of the future of lung cancer screening?
So when I'm counseling, there are a couple of things that I try to make sure of at all times. And the most important one is that we do see some false positives on these tests. Anyone who has ordered a great deal of diagnostic imaging knows that you find all sorts of incidental findings on these tests when they're ordered. And so patients can very easily become alarmed when you see a nodule. But I do remind them that quite often, in my experience, and this bears out across the board, these findings are not representative of a lung cancer. They're just an incidental finding that we take track of. So I think the biggest negative consequence of lung cancer screening that we see pretty much unilaterally is just worrying about it and a lot of stress that that can cause. I've heard people wanting to emphasize the radiation exposure, but I don't routinely recommend that just because it is a very minute amount of radiation. And I have not seen any negative outcomes from patients who have been exposed to it at this point, or I felt like it was a contributing cause to anything down the line. I do emphasize smoking cessation when counseling patients on lung cancer screening. That's a part of the standard shared decision making. And in reality, it's probably the best thing you can do for your patient in terms of their long-term health. My hope is that we would see counseling take a less of an emphasis going forward, because I do feel like a lot of times it's used as an impediment and a barrier for primary care physicians who are already trying to get everything done in a 15 or 20-minute session that they can, and then having to take out a 3 to 5 minute counseling session when that doesn't have to be done in any other form of cancer screening is really asking a lot that's not necessary, frankly.
Okay, great. Charles, the next question has to do with calculating pack years. It seems like a simple thing to do. but we've seen some issues with payment specific to stating the PAC year versus calculating the PAC year. Are you seeing this in your practice? Any tips or suggestions to avoid troubles with getting these scans authorized?
Yeah, interestingly, I just started seeing this in the last month or two. Before then, if anything came back to me, it was just because I had failed to document that the patient was a smoker, or that they had quit or something like that. But now insurers seem to be taking the tact of trying to not covering these because there's not clear documentation on the exact parameters. So whereas before the insurance would take my word for it that this person had smoked 53 pack years, I'm actually now seeing some pushback in that I have to show my work model, is what I call it. So essentially, this is the same idea of when we were all going through algebra in school, and you might know the right answer, but if you can't show how you got the right answer, you don't get credit for the question. So you actually have to document how many years the patient has accumulated, how many pack years per day the patient is smoking, how many years the patient has smoked in total, and then if smoking cessation has occurred, what year did this happen? So that basically anyone who did not know this patient at all could look at the note that you're sending to justify it and actually arrive at the same smoking pack year history that you have. So as long as you're putting all of those parameters in the notes to justify the screening, I have not seen any issues with insurance at that point, but it is a little bit more cumbersome than it was, say, a year or two ago.
Next question deals with the concept of reflex ordering. Can you describe this a bit, just describe the process, give us your thoughts about the pros and cons of allowing or selecting a reflex order set for positive screens?
Sure. So probably we're most familiar with this as primary care providers in the setting of mammograms, where if a mammogram comes back with an abnormal mass seen, there's a reflex order depending on the BI-RAD score. And same thing with LRADs and lung cancer screening. You're given the option if there is an abnormal lung nodule seen and you have a higher than a LRADS 2, then you can just let the screening center order a referral to a pulmonologist or to a subspecialist, whoever they designate, to deal with those abnormalities and make sure that it's followed up on appropriately. I think it's very helpful in that it helps limit the lag in getting patients who very possibly have lung cancer the treatment they need. As we all know, lung cancer is a very fast-moving cancer, and any delay can be detrimental to the patient. And frankly, it's one less thing that I, as a primary care physician, have to worry about, which is a lot. Con to it is that it does lose some of that aspect of handling things myself that I like, that degree of autonomy. I generally choose not to employ it myself, but I do think it's a very useful tool that likely is useful to a lot of physicians across the board, and personally have no problem with it. But just for my own personal sake, I tend not to use it as much and just call the patient myself and let them know what's going on and that we're going to get them in or schedule them for a visit. But as long as the patient is getting the care they need, any tool that helps with that is A-okay in my book.
Yeah, totally agree with that statement, Charles. Next question has to do with age. We sometimes like to talk about age when it comes to screening for cancer. As we know, patients either who are very young or very old typically don't benefit from screening, mostly based on statistics. But generally for lung cancer, what age do you consider? Are there any strict or hard cutoffs? What do you do in practice?
So in general, I start having that question in conversation with the patient around age 78, because this is the age that traditionally CMS has not covered. So if the patient, even though it's been recommended that they continue through 80, if the patient wants to continue through 80, they're going to have to pay for it themselves. And so obviously, whenever the patient is on the hook for the entire bill, we start looking a little more closely at, do I really want to do this? Is it really beneficial to me? I generally will stop routine screening at age 80 unless you're coming across a patient who is just in superb health and you really think if they do find something, then we can actually, the patient has a good outcome just based off of his baseline health. I tend to focus less on the age in front of me than the patient themselves. I certainly have patients who are only 60 and have so many comorbidities that I am not choosing to routinely screen them for lung cancer. because I don't think, regardless of what the outcome is on the screening, they're going to be here in 5 years. Whereas I have one patient who's 85, plays tennis every day of his life, but he quit smoking 10 years ago. And I have talked with him, and we agree that it's still in his best interest to get screened because he likely still has several good years of excellent health ahead of him. So those are kind of the baseline rules, but I will say that I deviate them quite a bit based on the patient in front of me.
Agreed. Yeah, we refer to that as biological age, at least when we're sometimes making decisions for cancer patients. And I agree, can certainly change your recommendation or opinion.
Absolutely.
Okay, next question deals with communication with your screening center. What tools do you find helpful in terms of communicating with your center? How are things typically done in your neck of the woods? What are some of the challenges or suggestions for improvement?
So the two things that I employ most and I feel like are most helpful is if the screening center has direct access to your EMR, so that whenever a scan is done, it can be imported into the patient's chart immediately. There's no lag in getting results. There's no miscommunication regarding where results go. I think the model that's employed more often than not is just faxing, which is fine, but obviously faxing leads to sometimes it doesn't go through, sometimes it gets picked up by the wrong person, and then it's lost to follow up. There are just a lot more caveats to that. So EMR access, the other side of the coin is that the screening centers can actually look and see when this person has had a diagnostic chest CT scan done in the last year, and they may not be due to repeat a lung cancer screening because that was done at an emergency room or in some other fashion, and now that screening has been satisfied for the next 12 months. The other thing that I feel like is helpful is just having a direct line to the patient navigator themselves. It's just being able to follow up and ask them, I've never gotten a result back. Did the patient cancel? Or, I got this LRADS 3. The report looks fairly benign, but should I be concerned? Just being able to have a little bit more of a personal touch than what's on the printed page a lot of times is useful, I find. So those are both areas where I feel like if you have it, you're lucky. And if you don't have it, it'd be something to push for with your providers.
Okay. Lastly, Charles, do you have a take-home message? What would you offer as a last thought here for any providers that order low-dose CT in our state?
So the biggest take-home message is that lung cancer screening is not a test, it's a process. So make sure you're aware of that. Make sure your patients are aware of that. They're not getting a one-time screening and being told they're not going to get lung cancer and then they're lost to follow-up. This is a process, and even when you have a normal test, it should still be a process to make sure that patient gets in for their next scan in a year's time. And certainly if there's an abnormal finding on the exam, you want to make sure that there's a process involved where that patient is getting the care they need, whether that is a biopsy, a repeat scan, what have you. A couple of other smaller points is just try to make sure you're referring to a quality center. Any site that offers care coordination, patient navigation, those are elements that are key in any successful lung cancer screening program. And then stick with it. Just lung cancer screening is continuing to evolve. It's going to be around for a long time. And frankly, it is a way that you can certainly save your patient's life if you stick with it and continue to try to follow up with each one of them at every chance you get.
All right, sounds great. Charles, thank you for your time today. Hopefully our audience might have learned a few things that they can use in their own sites. Look forward to seeing you later.
Yeah, thank you.
This is Dr. Munish Luthra. I serve as a faculty at Emory University School of Medicine in the Department of Medicine and Division of Pulmonary. Thank you so much for joining the 3rd annual Georgia Lung Cancer Roundtable. I am the chair of the Tobacco Cessation and Prevention Work Group, and I've been associated with the Georgia Lung Cancer Roundtable since last 3 years. And I think I've enjoyed working with all my colleagues. And I'm thankful to all of you for joining this virtual format. I wish we would have done it in person, but most likely next year. So without further ado, let me introduce our members. These are the active members that we have. I already mentioned about myself and my affiliations. And we have Ms. Colin Commons, who is our smoking cessation representative from the Department of Public Health. And she's the smoking cessation program manager at the Department of Public Health in state of Georgia. We have Ms. Astrid Wilkie-McClure. She is a community coordinator and an educator at Northside Hospital Cancer Center. And she's actively involved in education and community outreach programs for smoking cessation, prevention, and lung cancer screening. And then we have Ms. Alicia Wright. She is our point of contact and active member from the smoking cessation, from the smoking prevention group at the Department of Public Health in state of Georgia. And she is one with whom we collaborate on the smoking prevention programs within the community. So I wanted to highlight the important work that we have done over the last couple of years. And I must say that you all understand that most of us had a pretty busy last 1.5, 2 years, and our energy and our time was mostly focused on taking care of patients with COVID. But we started this initiative of Patient Information Guide. Our main objective was to have a kind of a document so that we can include in the smoking cessation toolkit, which could actually help our residents of Georgia who reach out to the quit line to discuss about the smoking cessation, but can also get information about the lung cancer screening program. Now, as you all know, that we have a kind of very robust lung cancer screening program in state of Georgia in different hospital centers, but we still see that the adoption of this program is kind of still not very good. So we thought like maybe this would be one way that we can probably advertise the lung cancer screening program to our Georgia residents who are reaching out to the Georgia Quit line for assistance with smoking cessation. So this patient information document was presented even in the last Georgia Lung Cancer Roundtable and was kind of approved by everyone. And now we have actually submitted this to the Georgia Quit line provider so that they can actually review it. And they have come back to us and informed us to kind of condense it to one page, front and back, which we're going to be doing soon. And our understanding is that as per the information from our colleagues from the Department of Public Health, that this should be incorporated in some shape or form, whether it's going to be mailed or whether it's going to be in the digital format, because the Georgia Quit line is considering seriously in incorporating this either in the digital or the paper format, which can be mailed along with the toolkit. So this, as you can see, the document actually is very concise. It is based on what, why, who, and how of lung cancer screening, and it is backed by appropriate references and the data from the state of Georgia. And at the bottom of this, if you could see, there is also a link to actually for the residents to click and find nearest approved lung cancer screening program as per the American College of Radiology. Moving forward, unfortunately, our Department of Public Health colleagues could not attend this thing as per their policy. So I just wanted to highlight that in the smoking cessation realm, they have included a link for the Georgia Quit line, which basically includes all the information about the smoking cessation program offered to the Georgia resident. Please feel free to use it and discuss with your patients and in the community. And it has a lot of resources, including the provision for counseling, which can be text-based, telephone-based, and at different durations as needed. In terms of the smoking prevention, the smoking and vaping cessation prevention education continued during the pandemic, but it was primarily more in the virtual format. And as per our educator, Ms. Astrid, they've had multiple partnerships with Fawcett County and the City of Atlanta Public Schools, and we will be continuing to have this more widespread in the time to come as we come out of the pandemic. They're also focusing on program evaluation with pre and post test as a challenge, post-test a challenge, but recently constant contact is being used as a tool for the same. So I think there is a lot of scope for working on the smoking prevention aspect. And as we move out of the pandemic, when we all have a little bit more time and energy, we'll start focusing on, and we have to kind of like reorganize our smoking cessation and prevention work group, which kind of got a little bit segregated because of the pandemic, and we will try to have more members who are interested. So please feel free to join us and reach out to me or Jessica, who can assist us in getting you connected and so that we can actually all work together to do some good work in terms of smoking cessation and prevention. In terms of future directions, as I mentioned, that we are hoping to finish and complete the patient information guide as soon as possible, and then waiting for the recommendations from the Georgia Quit line, that how they're going to be incorporating that in their smoking quit line. And then we'll be working with our Department of Public Health colleagues to see how we can advance programs in the area of smoking cessation and prevention in 2022 and further. And thank you so much for joining. This is basically what I needed to share with you all, and I'll be happy to take any questions. Thank you.
Hi, my name is Aaron Kahn. I'm the chair of the policy subcommittee, and I'm here with my fellow chair, Dr. William Mayfield, to discuss some of the policy issues that we have been addressing on the Georgia Lung Cancer Screening Roundtable. One of the issues that we've faced with lung cancer screening is the shared decision-making meeting requirement. This is a requirement that, as far as I'm aware, is unique to lung cancer screening. It's a specific requirement for a clinical meeting between the patient and their primary care screening team. This requires a formal charge code and is a considerable barrier to lung cancer screening. For example, women don't need to have such a meeting to have a mammogram, or you don't need it for a colonoscopy, but CMS requires it for lung cancer screening. While there's no dispute that patients should certainly discuss the applicability of lung cancer screening with their doctor, the specific formal requirement for this meeting and associated charge code is a significant barrier to lung cancer screening. It comes from the early days of lung cancer screening, when there was concern for harms from bronchoscopy and surgery, but these have diminished markedly over the last 20 years and should no longer represent a barrier to care.
So another issue that the screening community has with the screening guidelines are the 15-year quit rule. So we're going to use a patient's example to show how this is a problem. So first, this rule represents a perverse incentive to initiate smoking in order to qualify for lung screening. So we have a woman who smoked 30 pack years, but quit smoking at 55 years of age. She's now 70. It's been 15 years since she quit. She wants to start lung cancer screening. And under the current guidelines, she would have to start smoking again in order to qualify for lung screening. Second, at the same patient at 55 years of age, using the PLCO 2012 6-year predictor of lung cancer model, at 55 years of age, she has about a 1% 6-year risk of lung cancer. 15 years later, at 70 years of age, she has a 1.6% 6-year risk of lung cancer. That's a 60% increase. But because of our current guidelines, we will now deny her lung cancer screening because she hasn't smoked in 15 years. So at the time that she has an increasing risk, we're now denying lung cancer screening. Now, in the NLST subgroup of patients who had stopped smoking right at 15 years, when we studied those patients, they actually had a significantly higher reduction in 5-year mortality from lung screening than those who had continued to smoke. So the NLST data itself contradicts its enrollment criteria. So the 15-year quit rule is really just a holdover from the NLST enrollment criteria, and it's not a part of the Nelson trial or any of the other major trials. The other issue, particularly that proceduralists have, is with the 80-year-old or even 84-year-old screening limit. Age is not the primary indicator of a patient's physiologic status. And we judge patients' candidacy for procedures based on their physiologic status, not just on their age. Rob McKenna published the first significant paper on age and video-assisted thoracic surgery almost 15 years ago and demonstrated that the mortality rate for patients under 80 was around 1.2%, and those 80 and 90-year-old, the average mortality rate was around 2.5%. Again, this is video-assisted lobectomy, much less invasive than open surgery. Furthermore, in octogenarians and nonagenarians, if we detect an early stage lung cancer, then we might treat that patient simply with CyberKnife or stereotactic radiation therapy. That patient never undergoes surgery and still be cured. So cessation of a screening aid should be a decision between a physician and their patient, but not just an arbitrary number dictated by our federal government. Next slide.
Another arbitrary number in the current screening guidelines is the 30-pack-year smoking rule. Current criterion require a 30-pack-year smoking history for a patient to be eligible for lung cancer screening. That's based on the original guidelines for the NLST trial. There has not been any demonstration that only such patients benefit from screening. And in fact, there is strong data to argue that that many other categories of patients would benefit from that screening, but they're currently excluded. There is a recommendation currently on the table to reduce that to 20 years, but that still excludes, for example, flight attendants. Flight attendants from the days before lung cancer screening, before smoking was banned in aircraft, have much higher rates of lung cancer because of secondhand exposure. They are excluded from lung cancer screening by the current rules. Patients with smoking spouses, patients with other risk factors such as a strong family history of lung cancer, they're all excluded from current lung cancer screening because the guidelines are strictly based on the criterion from the original NLST trial. These criteria need to be updated and broadened to more inclusive criterion, such as NCCN and other guidelines that are available that expand these criteria to more patients that would benefit. This would particularly benefit a more diverse group of potential patients who are often excluded based on a 30-pack-year smoking rule, as strictly interpreted.
So the Georgia Lung Cancer Roundtable, through the National Lung Cancer Roundtable and with the Go To Lung Cancer Foundation, have shared these concerns directly with the CMS policy determination coverage group. And we feel proud to be able to represent the Georgia Lung Cancer Roundtable in that effort. Dr. Khan has led the policy group now for, I don't know, 6 or 7 years and done a wonderful job, and we're deeply indebted to him. So with that, I believe that we will close the policy group discussion, and we are open for questions. Thank you, Aaron.
Thank you, Dr. Mayfield.
All right, that was great. Hopefully we retained most of our audience. I thought the interaction from the different, from all of our different subgroup leaders was extremely helpful, and I thought it was interesting as well. We originally were going to pursue question and answer along with a little more of an expansion on future directions. And as always, we might have run a bit late. We're at 1 o'clock. I'd like to just take this opportunity to summarize the last segment, and then hopefully we can get this meeting closed within the next 10 minutes. Again, I apologize for the meeting running a bit long, but while I've got everyone, just in summary, we heard more of the quality triad from Norm. In terms of future directions, we'd like to always push to increase volume while maintaining quality. I think that's always the challenge. In terms of the navigation group, what I heard was communication with your patients, communications with your screening centers, and adherence to the recommendations. There was a call for reducing barriers to scans and reducing any sort of disparity that may come up with scans and patients getting those completed. From the provider group, Charles gave us an excellent summary about communication on reflex orders. Gave us a summary about practical knowledge. How do you counsel? Because it is still technically necessary and required. Charles continues to want to come up with some method to try to push this information that we're sharing towards our new and future providers. If we can make our way to the training programs amongst the state, family medicine programs, internal medicine programs, and beyond, in addition to medical student and APP training. From the tobacco group, we heard an overview of the toolkit, which should be finalized in terms of the information guide coming up. I know that our pulmonologist, Manish particularly, we appreciate you, but been terribly busy over the past year. Anytime we can get him to give us some of his time, we greatly appreciate it. But what he was discussing essentially was promoting this toolkit in different ways around the state. We always look for ways to reduce the absolute numbers of those smoking, and to find ways to prevent those from using smoking, tobacco, and other products, even vaping now that's on the horizon. From the policy group, got a nice summary from Bill and Aaron about what's going on at the national level, CMS advocacy. We acknowledge that some of these requirements are a bit outdated, such as counseling. We know that the quit rule may not be so important. We know that the actual smoking pack years may not be so important. I think it's important for us to be practical when we address the patient in front of us. And hopefully we see some of those as barriers actually go away entirely, or reduce in a way that makes it easier for us to do our jobs. We do have a fair amount of questions that were asked. We would like to do it, perhaps an executive council follow-up in the next 1 to 2 months. This recording will be available to anyone on this call. I plan to use not only Rana's statistics in our own hospital, but I'd like to for you all to feel free to share those with your own groups. I think the 40-minute segment that we just provided, that can be shared with anyone. I do plan on placing that on YouTube and hopefully discussing with Georgia Core in a way where they can share it in a meaningful way. In terms of our future direction, I would like to see subgroups next year focus on completing a quality improvement project, something simple that can be instilled in different hospital systems. I think every year we have to make it our own purpose to get better in some way, and to put something down that can be shared and used by others. In summary, I just would like to say thank you all for attending. I'd like to also say thank you to Jessica Davis for leading this group. If I was standing next to her, I would give her a gift card to the Back Porch, which is a very tiny steakhouse in Shellman, Georgia, where I bumped into her about 3 months ago. But we appreciate everything that you do, and I appreciate everyone taking time to take this phone call today. So thank you all. All right, are we adjourned?
Thank you, Dr. Jones, for running this.
Thank you. Thanks, Eric.